be expecting people to come on, but we do have to respect the time and start. So thank you very much for everyone coming in this afternoon. We do not take your presence here lightly, so we're going to make sure that it is beneficial to you as a practice. So this is no MASLD, which is basically management of, and in this situation, management and advances of sugar and liver disease. And this is the first of many series brought to you by Mega Life Sciences. This is just to foster good conversations, good growth within doctors in the space of gastroenterology and in the ecosystem of helping our patients on a daily basis. So, like I said earlier, this is the first of many series, and this will lay on speaking to the practice, advancements in the practice, and also speaking to case studies that will then foster growth within the gastroenterology space. This particular program definitely comes with CME points. I just needed to mention that, and which will be sent to us between 48 to 72 hours after the program. So with this being said, like I would hand over to the course director to speak more about the program. So thank you very much for your time, and please over to Professor Samalia.
Thank you very much, Sami, and thank you very much, Mega Life Sciences, for providing this unique platform. And thank you very much, Dr. Ganiyat Oyeleke, for finding time to coordinate this very important maiden edition of this series of what promised to be an exciting series of educational program supported by Mega Life Sciences. And our speakers, Dr. Chinwe Onyia from UNN Enugu, and also we have Dr. Alimi Abiodun from UCH Ibadan, who will take us through overview of this and then some case reports that we will share. As has been mentioned, this is the first of the series. And if you look at what we are here today to discuss is to know our liver and also to ensure that we take care of people that have metabolic dysfunction associated with steatotic liver disease. Either we prevent it or we diagnose it very early, and so that we can manage this patient before they reach the reversible stage of cirrhosis, or even the unfortunate few that may go to liver cancer. And so I think very important, our family physicians, our general practitioners, our medical officers, and all doctors across Nigeria, and in fact, sub-Saharan Africa, and also across the world that are joining us, and other members, including our gastroenterologists who are experts in this field. You are welcome to this very important talk. And we promise that this is going to be the beginning of many good things to come. And we, as you know, over the few decades, as prevalence of obesity increased, not only in the Western world, but also in our African population and the Nigerian population. As we adopt more and more Western lifestyle, less exercise and consumption of calories that doesn't match expenditure, as we have increased incidence of obesity over the years, we developed series of risk factors that was termed at one point to be metabolic syndrome or insulin resistance syndrome or the Revin syndrome or the deadly quartet, as the case may be. And these are the things we'll discuss today because it's increasing in our population. We need to have high index of suspicion so that we can prevent, or where unfortunate people develop this, we stop them at the level of steatosis without going to steatohepatitis or cirrhosis or liver cancer. And we know that around June last year, in the middle of 2023, so more than 200 experts across the globe assembled along with patient support groups or patient interest groups to look at the nomenclature for this very important metabolic dysfunction. Because they thought that the name of metabolic over the years has been stigmatizing, it's not all encompassing, and it's not too specific. And that is why they came up and adopted it from June last year, the metabolic dysfunction associated with steatotic liver disease. So we will listen to Dr. Chinwe Onyia and Dr. Alimi Abiodun, respectively, to take us through what probably, I think we are going to start with some pre-test, Sami, I understand, before the talks, isn't it? Yeah. So I think I'll hand over to Sami and
yes. So thank you so much, Professor Samalia.
Thank you very much. Yes. Thank you very much.
Thank you very much, Professor Samalia, for giving us the opening. And we thank Mega Life for putting this up. So we're starting right away. My name is Ganiyat. I'm a liver specialist, and I work at the Lagos University Teaching Hospital. So I'll be the moderator for the event, and we're starting with a pre-test. Can we have the pre-test on, please? Can we please have the pre-test? Yes. So please go ahead and let's do the pre-test. Question 1. So we have just a few minutes for this before we kickstart the program further. Thank you. We welcome the people joining. We're doing the pre-test right now. So we have about 3 minutes to do this, 1 minute gone. So we're welcome to this webinar. The webinar is on metabolic associated steatotic liver disease, which is the new nomenclature for fatty liver, non-alcoholic fatty liver. So we'll know more about this after this pre-test. Thank you. So we kindly encourage people to please participate. It's just would like everyone to be part of this. Thank you very much. We're going to stop it at the 3 minutes mark. So we just have a few more seconds to go. Then we'll start the presentation with Professor Onyia, sorry. Dr. Onyia. For those that are joining, we're doing the pre-test. Please join. We have just about 3 more seconds to go, and we end the poll. Thank you very much for joining. All right. So so right now we're starting I think I'm ending the poll now. Is that good? Yeah. Okay. So right now we're starting the lecture proper. Today's lecturers are 2. So we have Dr. Alimi, who will be doing case presentations. We have 2 cases, very interesting cases to present. And we have a presenter who is going to discuss metabolic associated steatotic liver disease. She's our keynote speaker, and the first speaker in the series has been introduced. Dr. Onyia is a consultant gastroenterologist and at the University of Nigeria Teaching Hospital, Enugu. She's a fellow of the West African College of Surgeons and an associate of the National Postgraduate Medical College. She's a researcher with publications in local and international journals, and she's affiliated with many professional bodies. Ladies and gentlemen, I hereby present Dr. Onyia to start her lecture. Thank you very much. Over to you, Dr. Onyia.
Thank you, Dr. Oyeleke. Thank you so much. Dr. Oyeleke was my teacher and trainer in Lutz. And so you can imagine my joy and honor to Life Sciences. Time to come see us this evening and for us to, talk about this thing that is happening in our generation now. And so, this evening, we are going to talk about gastroenterologists reached out to me and said, my cancer has become like a pandemic.
Sorry.
And
Dr. Onyia.
Yeah,
Sorry.
Can you hear me?
Yeah, I think there was a time that it was fluttering a bit. So I don't know if you can just start again. And we'd like to encourage people to also participate. So if you have questions, just note the questions. Then we'll have at the end of the meeting, as stated in the agenda, we'll have question and answer section. So Dr. Onyia, the line was breaking and we couldn't hear that first part of the introduction. So please, can you start?
Good evening. Can you hear me now?
Yes, it's better now. Thank you very much, Dr. Onyia.
Okay, so I was saying good evening. My teachers, Dr. Oyeleke Life Science, saying that a colleague of mine just before SOGIN 2024 reached out to me and said, Ma, I think there is a pandemic. I think liver cancer has become an epidemic and it seems as if nothing is being done. Why don't we do more radio advice, more? I come from the village. Doctor, if you're able to get those doctors and help them, catch them early, then you have done a lot of good for them. So you can imagine my joy when Mega Life Sciences, by setting up, I was saying, we have a silent epidemic. Dr. Oyeleke, your hands are up. Can you hear me? Hello, Dr. Oyeleke.
Continue, Onyia, we can hear you. But just breaking sometimes, just continue.
Okay. All right. Okay, so we have a serious epidemic at our hands. Liver cancer in sub-Saharan Africa is becoming an epidemic, and in Nigeria, the incidence is a problem. Currently, it is the third commonest cancer among males, and then the top 5 commonest cause of cancer deaths in Nigeria. And liver and the breast cancer and prostate cancer, they've received a lot of attention, even from the government, but liver cancer still lags behind for some reason that is unknown to us. Next slide, please. Okay, so what are the causes of liver cancer? There are so many causes of cancer, but for this for the program, we're going to look at chronic hepatitis B and C, and then we have the alcohol, and we look at the MASLD. So what's the call to action? What are we expected to do? Next slide. WHO recently has advocated a public health approach. What is a public health approach? It is advocating that the management of liver cancer, and indeed most of the liver disease, should be decentralized from the specialists. How many GI specialists do we have compared to the whole population in Nigeria? And so they deemed it wise that the best thing to do for the management of liver cancer, and indeed most of the chronic hepatitis, and especially hepatitis B, is to decentralize its treatment. So what is their approach? That we screen everyone that has not been previously screened for viral hepatitis B and C, especially at the primary care level. In fact, what I do, once I come in contact with every patient, whether you have headache, whether you have malaria, you know, this malaria typhoid syndrome, I treat malaria every month. I treat typhoid every month. I just screen for hepatitis B and C. I think it's a very good strategy, especially at the primary care level. They may not come to the teaching hospitals, but I'm sure they will come to the village hospitals, to the cottage hospitals, to the peripheral hospitals. So let us learn to screen everybody that has not been previously screened and is not vaccinated for hepatitis B previously. Okay, so now when you screen, what do? If someone tests positive for hepatitis B, there are other tests you're supposed to do. Ideally, you're supposed to check the HBV viral load, and the cutoff mark is more than 2,000. Additionally, they may or may not have elevated liver function. But you know that liver enzymes is not a good indicator of what is happening in the liver, because even in advanced liver cases, you may get a normal liver function test. So, but if the liver function test shows elevated AST or ALT, especially ALT, greater than 2 times upper limit of normal, associated with the elevated viral load, is an indication to treat this patient. Now, recently, the WHO reviewed their protocol and came up with new recommendations. Now they want us to check an APRI score. It's not just enough to do the HBV viral load and decide, oh, it's not up to 2,000. It's coming to everybody's notice that most people may never get to 2,000 international IU per liter, and at the same time, they come up with liver cancer. So the new recommendations are that you should check the APRI score. There is an APRI score calculator online. You just impute the AST and the platelet count, and it gives you a calculation. So if you get any score 0.5 and above, it's also an indication to treat, irrespective of what the HBV viral load is or whether the liver enzymes are elevated. Now, there are conditions that accelerate the progression of hepatitis B to liver cancer. One of them is the presence of diabetes. So if somebody has hepatitis B with diabetes mellitus, WHO says, current recommendation says, treat those patients. If somebody has fatty liver and chronic hepatitis B, it's also an indication to treat. If there is a family history of liver cancer, irrespective of what the HBV viral load is, it's an indication to treat. Now, another thing that is not on this slide is that when there is co-infection with either HIV or HDV, that's hepatitis D, or HCV, hepatitis C, once there is co-infection, is also an indication to treat. Now, if after screening the patient is hepatitis B, and okay, so let me go to the treatments. There are so many treatment regimens. We know tenofovir, we know the regular tenofovir that is 300 milligrams, then you know the alafenamide that is 25 milligrams that has been advocated for all the patients that have osteoporosis or have renal impairment. And then there is entecavir. And then sometimes it's not easy to get the one that is just tenofovir alone. You may have different combinations like tenofovir with lamivudine or tenofovir with emtricitabine. WHO says all those ones can also be used for treatment. But what we should not do is to place the patient on only lamivudine, because there is a high barrier of resistance. And most times the patient down the line, 6 months or so down the line, they lose it loses its potency and it becomes resistant, and the patient doesn't know and they feel they are on treatment. Now, supposing the patient test negative, it's not enough to say, oh, just go, you're negative, you're fine. No, the main thing now is to make sure these people are vaccinated. Anybody that is vaccinated, any population you vaccinate against hepatitis B and it's complete, you don't have to worry about them anymore. So recently, during our World Hepatitis Day activity, we screened in a UNEC Enugu campus. Unfortunately, we were not able to get the vaccines to the venue, but what we did was that we put them in a WhatsApp group, and currently, as I speak, by Saturday, about 100 of them will be getting vaccinated at their own expense. They're going to pay for it. But what we want to do for them is to follow them up to make sure they complete their vaccination, and then we let them go, and then we pack another group. So I think that if we can put in little strategies like this to vaccinate as much people as we can, when we vaccinate vaccinate them. We do to prevent mother to child transmission. Now, that childhood vaccination is very vital. In a study 2022 study, found out that the HPV vaccine at birth within 24 hours, all of them, 100% of them tested negative at 9 months. So it is very important that we advocate globally. Start saving for it by the time they come to you for counseling. What about my child? They start saving for it from inception. By the time the woman puts to bed, the vaccine is already there. Child transmission. Everybody. Next slide. 3 months therapy slide. Now, if the patient is abstain from alcohol before they get to the level of regress, dysfunction associated fatty liver disease. Next slide, please. Next slide. For fatty liver disease, we've already talked about the new nomenclature and how it came about. The fact that people wanted to remove the stigmatization that comes with attaching it to alcohol, and they want to attach it to what actually causes the disease. Now, if you go to the next slide, you will see the major causes. You see the major causes of major risk factor: obesity, diabetes mellitus, and in fact, those are the first hits. Then you have in fatty liver, which if not taken care of, can cause to hepatitis, steatohepatitis, from there to fibrosis, and then to cirrhosis and liver cancer. So what is the idea? What are we going to do about this? If you look at the next slide, we're looking at lifestyle modification. When you get these patients, don't just tell them, oh, it's just fat in the liver. You have to institute some form of lifestyle modification. If they are obese, they have to lose weight. If they are diabetic, their diabetic control has to be optimal. Hypertension has to be treated. Dyslipidemia should be managed. These are the things that induce insulin resistance that worsens the syndrome. The next slide. And then apart from lifestyle modification, which I've talked about, there are other components of metabolic, the liver-directed pharmacotherapy we can use. People have talked about deoxycholic acid. People have talked about vitamin E, omega-3, all kinds of diabetic drugs have been used. But the major thing that has been shown to work is the targeting of the metabolic components of metabolic syndrome, especially obesity. If a patient is able to lose 10% of body weight, that is a lot of things till you get to the top of that's WHO is about 1 to 600, but currently we are at 1 to 2,753. which is grossly inadequate. That's even worse. Especially doctors, especially at the primary care level, to identify and manage chronic liver diseases so as to reduce the complications. But part of this enlightenment also is also to help the doctors, medical officers, those that see these patients at the peripheral care level, to know when to promptly refer to a liver specialist. Together, we can stem this tide of HCC that is currently ravaging this country. Thank you so much for listening. I look forward to your questions. I don't know whether I was heard, but I am sure that if there are questions, I'll be able to take them. Thank you very much.
Wow, thank you so much, Dr. Onyia, for the beautiful presentation. Yes, we had some internet glitches and some areas were not so clear, but we hope that we'll be able to get the slides across to all participants. And if you have questions, we have a question and answer comments, please. Dr. Onyia is still around. Please keep your questions available. You can put them in the chat box while we go ahead with the next presentation. Thank you so much, Dr. Onyia. I mean, the summary is that fatty liver, or what used to be called fatty liver, is now called metabolic dysfunction associated steatotic liver disease. And she has given us the consequences of leaving it untreated or managed. And she's told us that there's strong correlation with metabolic syndrome, and starting with lifestyle modification and using some specific medications that target liver improvements, we can prevent the dreaded complications of cirrhosis and liver cancer. Thank you so much, Dr. Onyia. So we're now going to the next presenter. The next presenter is Dr. Alimi, and Dr. Alimi is the Senior Registrar at the Gastroenterology Unit at the University College Hospital, Ibadan. Dr. Onyia will be giving us the case presentation on what we see all the time. You know, most of us, even we doctors, we go to the clinic and we do tests and or maybe scans, and they find that we have fatty liver. What do we do? What are the typical cases we see in our practices, and what are the steps we should take? Thank you. So while we listen to Dr. Alimi. Dr. Alimi, over to you. Thank you for.
Thank you, ma'am. I want to appreciate and acknowledge the presence of my teachers, Dr. Ganiyat, Oyeleke, Professor Samalia, as well as Dr. Onyia for a very beautiful discussion. So I'll just take this case presentation. So please, next slide. So the first patient is a 50-year-old Islamic cleric that presented via the emergency department of the University College Hospital, Ibadan. Presented on account of lassitude, abdominal pain, and jaundice. Next slide. So until about 3 months before he came to the University College Hospital, he developed generalized body weakness as evidenced by effort intolerance, and then later exertional dyspnea. About a month before the first contact, he then complained of abdominal pain, which was predominantly in the epigastrum, insidious in onset, dull aching, and moderately severe. The pain was not related to meals, fasting, or bowel movement. He also alluded to having multiple episodes of vomiting. Next slide, please. Thereafter, he had jaundice that was said not to be deepening. He also had generalized disturbing pruritus and had also been passing coke-colored urine, however, no passage of pale bulky stool. Next slide. So at the last check, when he had no symptom, he weighed about 110 kg. And as Dr. Onyia said, this patient already had a risk factor for MASLD, and he had actually lost significantly over the past 3 months. His weight has dropped to about 96 kg. He also had anorexia, but he had no fever or drenching night sweats. He had never been transfused, not a known IV drug user, and no scarification, just to tell us that he has no traditional risk factor for viral hepatitis. He was not known with viral hepatitis, had no family history of liver disease. He had taken alcohol-based herbal preparation at the onset of symptoms, just like Dr. Onyia has also alluded to that some of our patients, they take different combinations just to feel okay. So on examination, he was conscious, not pale, he was icteric, was cyanosed, no significant peripheral lymph node enlargement, no finger clubbing, no pedal edema. His weight at presentation was 96 kg with height of 1.76 meter with an estimated BMI of 31 kg per meter square. The abdomen was forbidden with respiration. There was a right hypochondral tenderness with also epigastric tenderness. The liver was about 6 cm below the right costal margin. It was smooth, it was tender with a span of 18 cm. The spleen and kidney were not palpably enlarged, and ascites was not demonstrable at the initial presentation. Other systemic examination were otherwise, they were normal. Next slide. So he had an ultrasound scan done that revealed hepatomegaly with sonographic span of 22 cm at the right mid-clavicular line. The liver, however, had poor parenchymal ecotexture, increased echogenicity, but with irregular outline. And the gallbladder and the spleen and other viscera were said to be normal. So the liver function tests, as can be seen here, the total bilirubin was 5.4, the direct was 5.1, and then the GGT was markedly elevated, 787. But surprisingly, the ALT was normal. Despite the 9 months course of this patient's illness, the ALT was persistently normal, just like Onyia had said that the patient can actually have a problem with the liver, but yet some of the liver enzyme may actually be normal. So overall, what this means is that the patient has conjugated hyperbilirubinemia, mixed pattern, predominantly cholestatic with hypoalbuminemia. Next slide, please. So other investigation as shown here. Of notes is that the CRP was elevated, but his ESR was just marginal, but because for his age of about 50, he probably expects this kind of ESR of 24. The electrolyte urine creatinine, he had hypokalemia. However, when we did the fasting lipid profile, we'll see that the HDL was quite low, 12. Every other parameter in the fasting lipid profile pattern will be normal, except the HDL, and that's already also tell us that this patient has features to suggest dyslipidemia. So next slide, but his RBG was normal. Next slide, please. So we also ordered for tumor markers, thinking that this patient may actually have a cholangiocarcinoma, especially with the way the patient had presented with pruritus, jaundice, and all. So the CA19-9 came out to be 203.6. However, when he also had some exhibition, it even went ahead as high as 700, but it also came down thereafter. So the AFP was within a reference interval. The viral screening were negative. Only the HB core, anti-HB core total was positive. However, we went ahead to do the DNA to exclude occult HBV infection, and the HBV DNA was not detected, telling us that it is unlikely that the previous infection with hepatitis B could solely be responsible for the clinical presentation seen here. The anti-HCV was also done, came out negative. Viral screening was also negative. The coagulation profile was otherwise normal. Next slide, please. So he then had a CT scan done that showed the liver span of 25.8 cm. It, however, shows diffusely decreased parenchymal attenuation. Other organs view were said to be normal, with features said to be in keeping with fatty liver. So we then went ahead to do a liver biopsy for the patients, and what that shows is diffuse fatty metamorphosis with macrovesicular portal triaditis involving more than 90% of the hepatocyte. There was also fibrosis, and the features were said to be in keeping with acute and chronic steatohepatitis. So next slide. So fibroscan was also done, which was used to assess the liver stiffness, which also corroborates what was seen on histology, with liver stiffness of 43.8 kilopascal, a value that is said to be consistent with F4 fibrosis. Upper GI endoscopy done reviewed esophageal varices, and the diagnosis was that of liver cirrhosis secondary to MASLD. So in managing these patients, we did variceal banding. The patient eventually developed some complications such as ascites, spontaneous bacterial peritonitis, even upper GI bleeding at some point, which were conservatively managed. The patient was counseled on the need for a liver transplant to reverse. However, due to fund, he couldn't afford that. Unfortunately, we lost him after he developed hepatic encephalopathy that was unresponsive to treatment. So I'll now take the second case. Next slide. So the second patient is a 55-year-old man that is married, presented with weight loss and right upper abdominal pain. Next slide. So he also had unintentional weight loss, as evidenced by losing of previously fitted clothing. He had anorexia, early satiety. He didn't take alcohol, never smoked cigarettes in any form, and had no yellowness of the eye. Next slide, please. So he also occasionally take herbal medicine. You can see that it's almost a recurring theme in most of the patients that we get to see. One way or the other, they are taking herbal preparation, whether alcoholic based or water based. He had no history of malignancy, family history of malignancy, no issue to suggest cardiac, hepatic, or thyroid gland impairment. He's known with hypertension, but not previously diagnosed with diabetes mellitus. Next slide, please. So the main finding on clinical examination is that his weight was 97 kg with height of 1.7. BMI was 33.6 kg per meter square. Again, the liver was enlarged, 8 cm below the right costal margin. It was firm to hard, non-tender with blunt edges. The liver span was 20 cm. The spleen was not palpably enlarged. The kidney was not bimanually ballotable, then palpable. The DRE was unremarkable. That systemic examination was essentially normal. Next slide. So he had viral screening done. Unlike the other patients that had at least evidence of past hepatitis B infection, he did not even have anything to suggest that he had been exposed, as anti-HB core total came out to be negative. The surface antigen was also negative. The anti-HCP was negative. The alpha fetoprotein was elevated 1,229 with upper limit of normal being 7. And the PCV was also low, 22%, which typically in our own environments, the average PCV for patients with HCC, particularly in University College Hospital, is about 26, 27%. So this patient just a little bit below that level. Next slide. So we then ordered for a triple face abdominal CT that showed multifocal arterially enhancing lesion that was said to be consistent with hepatocellular carcinoma on a background of liver cirrhosis. And this patient was placed on 3-weekly atezolizumab bevacizumab combination, of which he had about 3 doses before he then opted out of treatment. So next slide. So what are the lessons that we have learned from these cases? So the first thing is that MASLD is here in Nigeria. Obese individual at risk of disease progression, liver cirrhosis and liver cancer can result from what we seemingly call fatty liver. When it is just reported that patient has fatty liver, we can see that this can actually result in liver cirrhosis and liver cancer. So prevention, like Dr. Onyia has actually alluded to, remains important to forestall the danger therein. We don't want to add to the numbers of liver cancer from hepatitis B, and then this will now be another endemic. Thank you for listening.
Thank you very much, Dr. Alimi, for these very interesting presentations. And I think the case presentations were quite concise, straight to the point, and you clearly highlighted the dangers of living MASLD or fatty liver, as we used to call it, and what the consequences of what they could cause. So now we have the next item on the agenda, the question and answer series. So yes, so we have the question and answer now, and we have some questions already on the chat. I don't know, can we unmute to allow people to answer directly, or what do you think? Okay, so I'll just read out the questions and allow the speakers. So the first speaker, Dr. Onyia, there's a question here on the chat that says, yeah, I don't know if you've seen it as well. So he said, thank you for the presentation. What is the duration of the treatment and the targets of follow-up? Dr. Onyia.
Okay, thank you very much for the question. For initially, the target is supposed to be seroconversion from probably somebody that is envelope antigen positive becoming envelope antibody positive. But we know that most of our patients here present with envelope antibody positive. So most of them don't even have the antigen for you to say you will treat until they lose the antigen. And most times it's almost impossible to seroconvert while on treatment. I'm yet to see a patient seroconvert from hepatitis B surface antigen positivity to surface antibody positivity. But what we look at is several things. So for example, If the patient does not have cirrhosis, if there is presence of cirrhosis, the treatment is almost for life. They are on the oral drugs, all those drugs I mentioned, almost for life. But if there is no cirrhosis, you can use other parameters. If the liver enzymes were elevated, you could use them to monitor progress. But most times, just like I said, the liver enzymes are usually normal. So what you do is, you can allow them to be on the medications for say 2 years, 3 years, and then monitor progression. And sometimes try to give them like drug holidays and see if the viral load continues to remains low. Do you understand? So if the viral load remains low, they can continue being on monitoring until if there is what's it called again, breakthrough or a relapse, and the viral load starts rising, then you may need to place them on the medications. Really, we are very careful about saying that you cure hepatitis B. You actually manage it, and it's a bit delicate. But the most important thing is that if a patient merits to be on medication, to say thank you.
Dr. Onyia, I think we lost you at the tail end of that. I don't know if you can just repeat the last closing statement you said. Hello, Dr. Onyia.
Can you hear me now?
Yeah. Oh. Yes, we can hear you now. Professor Samalia, do you have?
Can you hear me now? So
yeah, maybe I just wanted to help out since her network.
It's usually difficult to say.
I think the question the person asked, the person that asked the question, that is Halilu Aliyu, did not specify whether he was talking about hepatitis B or hepatitis C. He just said if you qualify for antiviral, what is the duration of treatment? And I think she's referring to B there because she did mention the FINET therapy using the DAL for the hepatitis C virus. If you don't have cirrhosis, you treat for 3 months. If you have cirrhosis, you treat for 6 months. And that you can look for sustained virological response. But for B, whether you are E negative disease or E positive disease, I think the tendency now all over the world, most guidelines is to treat for life because in those days, they used to talk about consolidation of 1 to 2 years. You have serial undetectable viral DNA, and then normal ALT, no evidence of cirrhosis. You consolidate, and after a year or 2, you withdraw. But there's a high incidence of relapses, even after consolidation. So the tendency now is to treat hepatitis B, as Dr. Onyia said, being a DNA virus that is embedded in our DNA because of the CCC DNA in our nucleus, to treat for life, whether you are cirrhotic or non-cirrhotic, or you are E-antigen disease because of the particular viral behavior of this particular DNA virus. I think that's it. And then somebody asked about CAP also.
Yes. So I think the second speaker will take the CAP question. So he was asking if CAP would have helped instead of doing an invasive liver biopsy for the first presentation. I think the first patient you did a biopsy. So Dr. Alimi, can you respond to that?
Yes, ma'am. Yeah, thank you for that question. Well, we don't actually have facility for CAP, but definitely liver biopsy will still be the best thing, because when this patient presented, we were thinking of obstructive jaundice and we don't know exactly what it was. So, and the best thing to actually do in that case was just to opt for a liver biopsy so that we can have a definitive diagnosis and then chart a way forward. So that was why we did the liver biopsy. Of course, CAP will have also helped us to estimate the amount of fat, but it won't tell us about the level of inflammation, just like it was given by the histology, where it was said that these features were in keeping with acute and chronic steatohepatitis. CAP won't be able to do that. Thank you.
All right. Thank you very much, Dr. Alimi. I hope that answered the question from the person that asked and the comments. Dr. Onyia, there's another question here. Do we still treat background hepatitis C in patients who have already developed liver cancer?
Okay, that question is very, very tricky. In fact, my professor in UNTH usually asks you why you want to bother this patient without therapy. But, so for example, if the patient has a chance to go for liver transplant. Okay, so if it's going for, the patient is going for liver transplant, yes, but you know, there is no liver transplantation currently in the country, although that place to do the liver transplant. I still treat and then go ahead to give therapy for PLCC. I don't know what your experience is, ma. Maybe you throw more light on that.
Professor Samalia, do you want to take a shot at this?
No.
I do the same. I treat for patients that I know may benefit, and I mean, if they're depending on the stage, if we want to give treatment for HCC, we go ahead. But of course, you have to also be mindful of if there is already dissemination and metastatic disease, what's the benefit really? So I think there's no blanket statement, and that's the same everyone does. You have to look at your patient in totality and look at the benefits of the treatment at this time. Dr. Samaila.
I think just to add something, I think, you know, treating these viruses, depending on the stage you catch them, there are primary and secondary endpoints. Once you have cancer developing, whether you are on a background cirrhotic liver or de novo that can happen with hepatitis B, now as Dr. Ganiyat has said and Onyia, if you think that it's a resectable lesion or transplantable lesion based on the Milan criteria, of course, you have to clear whatever virus you have there, because if you resect either segmentectomy or partial hepatectomy or lobectomy or transplant, as the case may be, so that the virus will not be there. But if it's already an advanced tumor that doesn't qualify for this, I think the shift now changes in terms of limiting the growth of that tumor rather than trying to load a lot of this into the patient when the tumor is multiple and has spread all over the liver. I think that's in terms of the treatment, depending on the stage you catch the patient.
All right. So there's another question on liver transplantation. Is liver transplantation available in Nigeria? If not, what can be done in terms of referrals? Where can people go? You know, because you mentioned that, I mean, I remember the first case, Dr. Alimi, that, I mean, we couldn't do a liver transplant. You discussed that with the patients. Do we have liver transplantation available, or is there a pathway to referral in Nigeria?
Currently, there's no that over liver transplantation in Nigeria. You know, we discussed this even at the Just Sogin some few months ago, and where Kano was adopted to lead the way, because during the 2022 Sogin in Kano, there was a lot of talk about one of the theme is liver transplantation. And because we have been doing kidney transplant for the past 2 decades, we've done more than 100, and they have a liver transplant committee that has been working on. So Sogin adopted Kano, and even the national district formed a committee now to see whether we can work as a country to support Kano or to in the next 2 years or 3 years to be able to transplant liver, as we have been transplanting kidneys for the last 2 decades. Well, currently you can only refer the patient to South Africa, Egypt in Africa, where you can get liver transplantation, or India, as the case may be. But in Africa, Egypt, South Africa, and I think Morocco is coming up. These are the countries where you can refer patients for liver transplantation, apart from Asia and other parts of Europe. And,
all right, thank you very much, Professor Samaila. Another question for Dr. Alimi. What was the second, the BCLC staging of your patient, the second patient, before the treatment of HCC commenced?
Yes, ma'am. Thank you, ma'am, for that question. It was stage B, ma'am.
Okay. So the question is in the chat, actually. It was asked by Jennifer Allo. And she also wants to, can you elaborate on the fibrosis staging discordant between the biopsy, which was metaphor stage 2 or 3, and fibroscan that was already cirrhosis? Yeah, so.
Yes, actually, they were done at different times. So okay. The fibroscan was done after the biopsy had been done. So it was more for our own learning that we just opted that, okay, let's just do fibroscan and see what exactly was there. So that's about like a 4-month interval between the biopsy and the fibroscan. So that may likely explain. And then this patient actually presented with features of decompensation, later on developed ascites and all. At the initial time when he came, when we didn't have ascites, but that was when we did the biopsy.
All right, thank you very much. So Dr. Onyia, can you just give us I mean, some of us are maybe in general practice, they see patients with fatty liver, maybe a step-by-step approach of what can be done. If you see a patient with fatty liver, what tests should you do? What are the things to look out for, or what can you do for this person? Just maybe like a few minutes of a recap, please. Thank you.
Thank you, Ma, for the question. Okay, so you do an ultrasound, and then it says fatty liver. Most times the patient is ideally want to do a liver function test, which may or may not be abnormal. Okay, so the next step is to look at the metabolic parameters. Is this patient hypertensive? What about diabetes? You want to do a fasting lipid profile to look for hyperlipidemia or dyslipidemia. And then if this patient is obese, for example, or overweight, it's not just obesity, even overweight has been linked to fatty liver. You will want to place this patient on a form of diet therapy, and then in addition to exercise or anything that will help in weight loss. Remember, it has to be a gradual weight loss because rapid weight loss will also cause fatty liver. So, so the treatment depends on what you find, but the most important thing is to screen for the metabolic risk. If the patient is diabetic, make sure there is optimal control of the diabetes. If there is hypertension, make sure there is optimal control of the hypertension. And then if there is hyperlipidemia or dyslipidemia, you give statins. Remember, statins is not to affect the fat in the liver. The statin is to take care of the lipid in the serum. That's the serum lipids, okay? And then apart from these lifestyle things, remember there are some other things that have been found to be helpful, like adjuncts. So for example, the phosphatidyl lipids, which we find in Yourliverwecare and all other things like that also help, but it helps as an adjunct to what you're already doing, the lifestyle changes, and then taking care of the metabolic risk. And then other things have come up. Omega-3 has been muted, vitamin E, deoxycholic acid, all those things have, some say it works, some say it doesn't work. But the most important thing we need to do is to take care of those metabolic risks. That is what has been proven beyond reasonable doubt to work.
Thank you so much. Thank you so much for this, Doctor, for the quick roundup, Dr. Onyia. And someone also posted something that it is clear that the public health approach as advocated by WHO to its member states presents a viable pathway for successful population-based management. Finance and political will are key to this. What efforts are currently ongoing in Nigeria towards this? Maybe I'll allow Dr. Samalia to do a quick roundup before we close for. We just have a few more minutes before 4. Professor Samalia, please, can you do this?
NAFLD or the hepatitis?
Yeah, no, so there's a question about, the modalities. So now, I don't know, is it related to the hepatitis or to the fatty liver now? I don't know if the cargo. So we can do for both, really, and let's.
Is it the box?
Yes, it's in the box.
Okay.
So it's given a chance to advocate for greater scope of coverage. What else would the presenters wish were covered? So I don't know.
I think it's related to what somebody have just asked. Okay. I think already we are doing well as a country for the past 3 decades or so in terms of universal coverage for the hepatitis vaccination. The bad dose is still not as good as we expected. That's the only way we can take off hepatitis B in the next couple of decades. Up till now, there's no vaccine for C. Fortunately for us, it's a curable virus with 3-6 months of therapy, depending on your profile. But I think that bad dose, to be able to get it, whether you deliver in the hospital or you deliver in the community, every child that is born in this country should have access to the bad dose of hepatitis B vaccine within 12 hours or 24 hours of that. Okay. And you get the subsequent vaccination. That's the only way we can take off hepatitis B. Otherwise, continue to see these ugly HCCs coming up. As for the other things, of course, the NHIS or the NHIA covers tenofovir and entecavir and other care, but they don't support liver transplantation. But that's not why we should go as a country. The public health is to prevent the infection in the first place, prevent people from getting it and diagnose early and prevent it from having cirrhosis and cancer. I think that's the way to go for the public health. Thank you very much.
Perfect. Thank you so much, Professor Samaila. Thank you, everyone.
I'm seeing Lighton. I'm greeting her, specifically my good friend Lighton.
Okay, yeah. So I'm handing over to Ms. Lighton to round up and give the vote of thanks. And please would invite you to join us again for another interesting episode on fatty liver or MASLD or metabolic dysfunction associated steatotic liver disease, whichever one you'd like to call it. It's been a lovely time here. Over to you, Ms. Lighton. Thank you.
On behalf of Mega Life Sciences, I would like to thank everyone for joining us today. It's been a very beautiful afternoon. Thank you, Dr. Onyia. That was a very wonderful presentation. Thank you, Dr. Alimi. And of course, our faculty, Professor Samaila and Dr. Ganiyat Oyeleke, you've been wonderful. You've made the session very interesting. Mega Life Sciences would like to thank all of us for joining. And Mega Life Sciences initiated this series of learning in management advances in sugar and liver disease. And this is to let us know that we'll be having experts in the field of endocrinology and gastroenterologists going forward. This is just the first of the series. Why did we do this? In line with WHO recommendation that the treatment of liver diseases be decentralized from experts to general practitioners. It then means that the knowledge needs to cascade downwards. And because of this, Mega Life Sciences took the initiative to start this series of lecture whereby we will learn. So three-pronged approach. We will learn, there will be education, and Mega Life Sciences over the years has also provided free screening of hepatitis B surface antigen tests for over 100,000 people in Nigeria so far. And we also raise awareness in providing education. So this will continue. Please tell your friends to join us. It promises to be interesting. We hope to bring experts from international speakers as well as different specialties. So the module 2 will be announced, the date and the time of module 2 will be announced to us shortly. But my job is to thank our core faculty. Professor Samalia, thank you. Dr. Oyeleke, thank you. Dr. Chinwe Onyia, thank you. Dr. Alimi, Hakeem, Abiodun, thank you very much. It's been a wonderful afternoon. Thank you for joining. See you at module 2. Thank you.
Hi, everyone.
Thank you very much, everybody. Thank you very much.
Thank you,
everyone.
So they're asking for the
slides. Slides will get to you.
Perfect. Thank you.
Thank you, Sir Zamal.
That you have.
Thank you.
So yeah, bye-bye. Thank you. Perfect.
Thank you. Thank you. Thank you, everyone.